Hi, I'm Dr. Susan Swedo, and I am very pleased to be able to speak with you today and honored to be asked to address your Congress. It's an exciting day. 25 years, actually, after we described the first 50 children with PANDAS, pediatric autoimmune neuropsychiatric disorders associated with strep. And in that 25 years, we've had experience now with thousands of patients here in the United States and many, many more abroad, including numbers of institutions there in Italy who I know are doing a great job of recognizing and treating these children. Just want to share one story. I know you're going to hear more from some of the families themselves, but I think of a little girl who had a very abrupt onset of just horrific obsessions about having done something wrong. And she was tortured by these thoughts that she might have hurt somebody or killed somebody. All of this started when she was in her room at night, and it couldn't possibly have been true. And yet she had to go check. She wanted reassurance. She made her parents' life very difficult as she was struggling to understand what was happening to her. It was very rapidly, within just a few hours, accompanied by extreme rages and irritability, which we now understand is part of the fight or flight reaction that is so common to our children with PANDAS. Other children present with a much more subtle picture where the parents will remember that they actually had a period when they couldn't go to preschool. They had been attending very normally up until October, November, and then suddenly they couldn't leave their mother's side and would kick and scream and show such distress when they had to be separated from their parents. Or what about the child who presents with the feeling that they can't get dry after urinating, and so they wipe and they wipe and they wipe and they wipe. And then turns out that they start wetting their bed. Well, when all of these symptoms come together, that's what we describe as PANS, pediatric acute onset neuropsychiatric syndrome. So a child is just a star student, everybody's favorite, able to get along with anybody, easygoing, having absolutely no worries in the world, and the next day is tortured by obsessional thoughts or dramatic restrictions of their ability to eat or drink fluids, either because they're contaminated, they're poisoned, or just because all of a sudden they think they're too fat and they can't eat or drink. Those children, when those symptoms of obsessions, compulsions, or eating restrictions are accompanied by somatic signs like sensory sensitivities, new textures bothering them, or a urinary frequency, urgency, needing to go much more often than they needed to, but also going and then feeling like they never voided, sleep problems. Those somatic symptoms are accompanied by extreme emotional lability, depression. In 7-year-old children, you can see suicidality, and all of these things coming on literally like that. Overnight, within a few hours, within a day, or at most 2 days. Think PANDAS. And once you think about it, act on it. The difference between a child who ends up moving from one psychiatric medication to another medication to another medication, and the child who has symptoms so severe that they're hospitalized in a psychiatric ward, but then discharged a week later, completely cured, is prompt recognition and treatment. What is the prompt recognition? Just thinking about it, thinking, this seems unusual. I've known this family for a long time, and all of a sudden, this child is acting so bizarrely. Let me do a throat culture. Let me look and see if you might have mycoplasma, perhaps even one of the tick-borne illnesses. But the most common one in over 70% of the children is strep. Not strep pharyngitis, where they will have had a history of a sore throat, high fever, abdominal pain, but the sneaky strep that gives them rheumatic fever. And in this case, their sibling might have had a strep throat, and this child has only the behavioral aftermath. It's just like Sydenham chorea, rheumatic heart disease, or any of the other non-suppurative sequelae of group A beta hemolytic strep. And that is that the strep is avirulent for pharyngitis. Therefore, it lingers in the throat for more than 3 to 5 days, and cross-reactive antibodies are formed, which now my colleagues in basic and clinical work have shown beautifully is clearly related to basal ganglia inflammation. We can recognize it on a clinical basis, that very abrupt onset of symptoms of OCD, eating restrictions, and at least 2 of the 7 categories you're going to learn about. We think, could it be infection triggered? Also remembering that sometimes it's going to be a psychosocial stressor. So it is appropriate to ask if that child might have been abused. But once you've ruled that out, pursue a biological basis for that child's abrupt change in behavior, obsessionality, and then treat. The first line of treatment is actually to treat with antibiotics. Even if you're not finding group A strep in the pharynx, it may be in the sinuses, it might be in the nasopharynx where your swab hasn't reached, might be perianal. And you treat with azithromycin or possibly augmentin, both of which also have very strong immunomodulatory properties, and you're going to see that child get better within a few days. Many times we will add a non-steroidal or even a short steroid burst like you would for a child with acute asthma. Again, miraculous cures in these kids, at least half the time. And I must say that I have a biased practice because I tend to see the kids that didn't respond to that first round. But when I talk to my colleagues in general pediatrics, they tell me, oh yeah, I treated a kid with PANDAS last week. He was such a mess, gave him a round of azithromycin, and he was fine, back in school within a week. If they don't respond to that first thing, it's really important that we continue to treat them aggressively. And here in the States, we use a 3-pronged approach. First one being antimicrobials, like azithromycin, augmentin. I understand there in Italy, you're fond of IM bicillin. If we had that here, I'd probably give that as well because it has a wonderful, persistent effect, antimicrobial effect. Second line of treatment is immunomodulatory treatments. I mentioned already, non-steroidals, oral steroids like prednisone. If those aren't effective, or if the child is quite ill, move right to intravenous immunoglobulin if you can. And for the profoundly, severely ill child, one who, excuse me, you're considering sedation or requires inpatient hospitalization, plasmapheresis or something equally invasive is appropriate treatment. The point being, the faster you treat, the faster that child can get well, the less chance they have of developing some of the sequelae of being sick. And that is learned obsessionality, learned compulsive behaviors, and ongoing anxiety. The final piece is one we struggle with here in the States, and I hope you don't there in Italy, and that is appropriate use of psychiatric medications and behavior therapy. You have to treat the symptoms while the child is ill. So in closing, I'm just going to ask you to equate PANDAS and PANS with pneumonia in an asthmatic child. You are going to treat the cause with antibiotics. You're going to treat the underlying immune abnormality with some kind of inhaled or oral steroid or other immune medication for their lungs. And then you're going to treat the symptoms. You're not going to let that child rack with coughs. You're going to suppress it to the extent necessary. Same exact thing for PANS. Get rid of the source by using antimicrobials. Get rid of the problems with the immune system with immunomodulatory drugs, and treat the symptoms with psychiatric medications and behavior therapy. And if you can do those 3 things, I honestly believe that we can save a generation of children from some of the misery of the adults that I've seen who had this as kids. Thank you again for your attention, and thank you for the invitation to speak with you today. I really do appreciate it.